So you said MRI is number one, yes? So your next presentation, it's about it. So prostate biopsy with MRI, US fusion. You have huge experience. So please, Dr. Trakymas, speak.
Thank you very much. Uh, I see that you see my slides, so I'd like today to say some words about MRI guided biopsies, which we started about 3 years ago, and it was the idea of MRI guided biopsies was to start with fusion biopsies, because with fusion biopsies we have a lot of possibilities to do different things. As I said, we have more. We can do the systematic biopsy, targeted biopsy with freehand, with grid, and so on. So at first, I'd like to remind you the new guidelines, the updates in guidelines of European Association of Urology, and what has changed. So I think you see this picture. You even saw this picture many times, but I'd like to remind that one thing really changed from the last year. That 1 year ago, this recommendation that is called perform a multiparametric MRI before prostate biopsy was weak. And today, this recommendation became strong. So actually, as I said, before doing biopsy of prostate, we are recommended to perform MRI and to see what's really going on in the prostate, not blindly, but as I said when we're discussing with Ruth Agrigene, that sometimes prostate biopsy helps us, not helps, but interferes with interpretation of MRI images. So the others, as I also said, for patients with prior negative biopsies, I don't agree that we need the systematic biopsy for these patients, because they are already biopsied systematically, and I prefer to do only targeted biopsy for those patients, and it should be strong recommendation. But it's my opinion, and the specialist think a little bit different. So, and today I'd like to say some words about fusion imaging. I used the fusion imaging for many years, not only for prostate and more for the ablation. I can fuse any image from ultrasound, from CT, from MRI, from PET, SPECT CT. If any image could be fused on one on another. But the idea to do fusion imaging on prostate for prostate cancers was very, very good idea. Of course, it's very difficult to do that. As you see, we need a lot of screens, desktops, to do the delineation of prostate and the cancer according to ADCT2 dynamic contrast enhancement imaging, and all these images project into one fusion software. When we prepare the MRI image, anatomic T2 image for the biopsy, we do all the delineation somewhere in the radiologist's workspace, and after that we transfer these images to the PACS and to the other place where we do the prostate biopsy, fusion prostate biopsy. And I'd like to say that it's a really versatile tool for prostate. We can use all the sequences and to fuse it with ultrasound. For biopsy naive patients, it's very important for negative patients that after the transrectally biopsied systematic patients. It's very important for patients after radiotherapy, and even if we are thinking about focal therapy, so this is number one tool for performing the focal therapy for the solitary tumors in the prostate. Also, I'd like to say that it's very important to have a tumor board for prostate, even for diagnosis, as colleagues from other hospitals also said on tumor board should decide what is the best solution for the patient. So we need a radiologist, interventional oncologist, urologist, radiation oncologist. Even before the biopsy, just having the clinical information and MRI images to decide which lesions should be biopsied. Do we need the only targeted biopsy? Do we need the biopsy at all? If there is real indications, clinical or imaging indications to perform these biopsies. And also, we need to think about possible treatment options to these patients if they really need treatment according to the present data. How many targets we need to hit? How many? Which lesions are the most suspicious, which are not so suspicious? As we saw yesterday, we can have a very big lesion that is Gleason 3+3, and a very small lesion that is clinically significant cancer. And as I said, how many samples for systematic biopsy? How many different things? All that should be decided on the tumor board, diagnostic, I would say, diagnostic tumor board. And this is the BioJet system that gives us all the information before the fusion biopsy. We do the delineation of the prostate. We do the delineation of the lesion. It could be seen on T2 images, but it could be seen only on ADC or DWI images. If it's one, it's one or two lesions. How many lesions? So everything should be delineated before the biopsy. And after that, the biopsy is taken with special equipment. We need the ultrasound probe that is mounted on the stepper, which is connected to software. And usually I prefer you do in transperineal approach. Of course, it could be done transrectally, but even new recommendations say that transperineal approach is more acceptable because of the infectious complications. So then we go to the sagittal plane and start planning the biopsy after the fusion of ultrasound and MRI images. We find the target and we try to hit it. Yeah, we at first we make a planning of the trajectory of the needle. Then we hit the lesion. We mark the site of the biopsy, and we can see it on the screen anytime, any day. We can return and to find out which which core was positive for cancer. So and take other cores. For this patient, it was targeted biopsy plus systematic biopsy, and we can see that all the cores were documented on the software. When we get the pathology report of each core, we can mark each core according to the result with different parameters. And as we see, we usually have some color coded. Green is benign, tumor red is malignant, more than the ISUP2, 2 or more, it's Gleason 3 plus 4 and more. And orange, we call this Gleason 3 plus 3 cancer. So as you see, this lesion was more suspicious on MRI, but we didn't get any tumor there. Just took Gleason 3 plus 3 course in a little bit different place of the prostate, but this tumor, this lesion was clinically significant cancer. So you can, after getting the result, you can make models of the treatment, what treatment you suggest for that patient, and again go to the tumor board and to discuss all the possibilities for the patient. As Barbara said, that actually all these cognitive fusion imaging and in-bore biopsies, more or less the sensitivity and specificity is the same. It doesn't differ a lot. Maybe cognitive is, I would say it's more difficult for the urologist to do, because you need to use a lot of neurons in your brain. But the results when you make comparisons of all these techniques, you see that all more or less you can find the cancer in all cases. And when you do the targeted biopsy without the systematic biopsy, according to the literature, we can miss 4% of the clinically significant cancer. According to the guidelines of European Association of Urology, we can miss up to 11% of clinically significant cancer not performing the systematic biopsy. So actually, it's not big deal, big issue. Keeping in mind that you, when you do the targeted biopsy, you take 2 or 3 cores, and when you do the systematic biopsy, you should take not less than 12 cores. And when you combine systematic plus targeted biopsy, it be much more, up to 20 or even more. It's the same with mapping biopsies, when you need to take the cores from every part of the prostate. So sometimes it becomes very aggressive way of diagnostics. So in National Cancer Institute, we up today we did 657 MRI guided biopsies, and the majority of them were fusion biopsies. As I said, we started with a more versatile tool to find out if it's really works, or is it really working, or do we get the biopsies, and the results were very good. Uh, Actually, we get only one clinically significant cancer only from systematic biopsy from all these cases, and there were much more clinically insignificant cases. It's I sup less than 2. It's Gleason 3 plus 3. That was diagnosed only from systematic biopsy, not from the targeted biopsy. So the cancer was hiding somewhere in the prostate from the MRI images. Or maybe we missed this while doing that. Actually, as I said, we prefer the transperineal approach for the fusion biopsies. That's why we have no infectious complications. Actually, we didn't get a lot bleeding complications. It's a minor bleeding after the biopsy. It's understandable. And what I found on the new guidelines, it's very important recommendations that, as I said, transperineal approach is very recommended for the prostate biopsy because of the infectious complications, less infectious complications. As you see, strong recommendation that you should use routine surgical disinfection of perineal skin for transperineal biopsy. It should be done in sterile way. When you are doing the transrectal biopsy, it's recommended to use rectal cleansing with povidone iodine solution for transrectal biopsy. And one strong recommendation that we do not use fluoroquinolones for prostate biopsy in line with the European Commission of final decision because of the fluoroquinolones are in some countries forbidden to use. So these weak recommendations maybe we can omit. And of course, it's very important to ensure that prostate core biopsies, all the cores from different lesions should come to the pathologist in separate containers to have a diagnosis of not any core, but just from cores from one lesion, from other lesion, and so on, to have some mapping and some idea what's going there. Okay. So, and these are my insights. What's is this fusion biopsy, fusion imaging for prostate? That we need to have a high quality MRI and ultrasound fusion targeting that could be used for targeted biopsies, the most important thing. Also, we can do with the same system, we can do the systematic and mapping biopsies, and to have all picture of the prostate. You can take the biopsy from any part of the prostate and to check if it's you can check around the lesion. If you are going for focal therapy, it's very important to have mapping biopsies, just to be sure that we don't have clinically significant cancers in other sites than it's visible on MRI images. And it's really very important for recurrence after radiotherapy of the prostate, because usually we use the contrast enhanced images, and while doing the biopsy, it's impossible to inject contrast and to find that lesion without fusion imaging. And also get the complete picture of all treatment for all treatment decisions. So we can later on, when we start the tumor board with our colleagues, today will be the fusion imaging biopsies day. So we will see how it's made, and we will try to make these treatment decisions together. So, and of course, safety profile is very, very important. So, as I said, I prefer to do transperineal biopsies in sterile way and not to get infections after the prostate biopsy. So, this nice guy looks very smart, but actually he's almost blind, and he can see very blurred vision. And when I see the prostate, I'd like to see it clearly each part of the prostate. So thank you very much.
Thank you very much. Thank you very much. So, is it MRI really number one?
I think today, yes. Without MRI, we can't do anything in prostate, especially when we are talking about single patient, unique patient, especially when we talk that we have a lot of treatment possibilities for those patients. So any information is very important. And many years we couldn't see the prostate cancer clearly, and now we see it with the help of MRI. So I think it's very next level to the prostate cancer treatment.
Do you have how many? Do you have any MRI negative cases when tumor is invisible?
Actually, I don't have
this
information. Yeah, because it's I usually see only MRI positive cases. So because we need to take the biopsy from the targets, from the lesions that are seen on MRI. So actually, I don't have the counts of the MRI when you have the PSA elevation and negative MRI. I think that the radiologists who do the diagnostics maybe have some ideas. Maybe we will ask it later on MDT discussion.
Okay, thank you. One more question. Yesterday we had Dr. Chuvashov's in speech about robotic assisted MRI guided prostate biopsy. What is your experience about that?
Yeah, as I said, we started the targeted biopsies with fusion imaging, just to be sure that we are not missing something with our MRI reports, our MRI visualization, and so on. And when we found that we can really find the clinically significant, so we started to do it with in-bore. And as we yesterday discussed, I think that in-bore biopsy is very good to do when you have small lesion, 6 millimeters, 8 millimeters, up to 1 centimeter in diameter, because sometimes actually even with fusion imaging can miss it. So if you have really small lesion, and then it's better to go directly to the in-bore biopsy to do correctly from that lesion. And Actually, yesterday we saw these cases that were done in Bor. Of course, you miss the systematic biopsy then, and every time you need to discuss that patient, what is better for the patient, just to hit the very aggressive lesion and to get the cancer, and not to make a lot of biopsies if you don't need to do that. So I think the future will show us which is better, but I think there is no better. Everything is good. Just you need to find the best solution for the patient.
So thank you very much.